This session's entitled Making Meaningful Connections, a Conversation with Clinical Leaders in Support of Quality Improvement. And when Lee and I started thinking about this, we said, oh, that'll be great. We'll have a small little round table. We'll have 10 or 12 of you. You'll tell us what we're doing right and what we're doing wrong and how we can go ahead. And that would be super. And then we found out that we would be amongst 300 of our closest friends trying to figure this out. So the challenge of this, we wanted to make a conversation. So the challenge is going to be that we have to get you to participate. And so even though this is not the setting that you would normally expect to have an intimate sort of conversation of pros and cons and backs and forth, we would ask you please to get engaged and come to the mics. Tell us where you think the direction should be, because that's what we want to get out of this. So I just wanted to set the stage a little bit. Then we were going to talk about some of the priorities, enablers, and challenges, and then we'll go on to where does HQO fit? Where could we do a better job? What would you like to see us doing? What are the priorities that you have for us? So the context is that in 2010, the ECFA, the Excellent Care for All Act, was introduced, and that became the genesis of this iteration of HQO. And if you look at that act, it's very explicit about several things. It talks about patient experience. It talks about excellent health services for all Ontarians. It also talks about high-quality health care and the areas of quality they refer to as accessible, appropriate, effective, efficient, equitable, integrated, patient-centered care, and as well as population health focused. But it's important to note that they also refer to this systemic culture of quality right across the organization, and that it has to be a quality focus for every provider. And that's the genesis, I think, for the discussion that we're to have today. I think a lot of good work has taken place in quality. When I look across the system and talk to individuals, look at my own circumstances, I think that there's a lot being done, but it's fragmented. I don't get the overall sense of an overarching strategic direction. Are we building the right infrastructure? Do we know where we're going? And is everybody on board? And I think that's the challenge that Lee and I have, and we're going to introduce ourselves in a minute, but the challenge that we have and the challenge we want to put to you today is, what is the role of Health Quality Ontario and all of us in the room in this next few years, this next generation? So, if I can find that, there's a few things that we have to do here. So I'm Dr. Jeffrey Turnbull. I'm the Chief Clinical Quality, and I'm newly minted in this role. So my other life is that I'm the Chief of Staff at the Ottawa Hospital, and my clinical practice deals with poverty and health. So, Lee?
Yeah, and I'm Lee Fairclough. I'm also relatively new to Health Quality Ontario in the last 6 months as the Vice President of Quality Improvement. And my background, I started in healthcare treating patients that were facing cancer with radiation treatment, and had many opportunities at Princess Margaret Hospital to look at how we could improve the delivery of care through trialing things like computerized physician order entry for the ordering of drugs and what that meant actually for how we wanted to deliver care, to also how we were supporting patients that were enrolled in clinical trials. And then after that, got very involved working regionally through Cancer Care Ontario, and the last 6 years have had a wonderful opportunity working with the Canadian Partnership Against Cancer to see how we could have a coordinated cancer control effort in the country. So I feel very privileged actually to be in this role at HQO, and I'm really looking to working with you and determining how best we can support you in your efforts.
So this is an ideal opportunity for us to, new leadership at HQO, and an opportunity for us to rechart a direction for that. And before going further, whereas Lee and I are the presenters. The real brains behind this whole operation is Shilipi Majumdar, and I think we'll probably forget later on, so I thought I'd take this opportunity of saying that if everything goes well, that's because of Lee and I. If there's any problems, it's Shilipi. No, honestly, she's done everything, and she is the brains behind today's operation, so a special thank you. We have no commercial or otherwise interests. We have had no commercial support, and we have no conflicts of interest. And I didn't think I would ever say, please tweet with me in my life. I never said those words would come out of my mouth, but nevertheless, tweet with us, please. So what we wanted to do after that brief introduction was to basically enter into a conversation about how we could accelerate, optimize the quality agenda, and how could we're going to identify areas of opportunity, how we could connect and leverage our combined capacity. How could we function as a catalyst to make a coordinated effort towards quality so that we serve our population better through healthcare. So I'm going to turn to Lee. She's going to take the first bit, and Lee's going to work you through a survey that's been done. She'll tell you all about it, but basically the priorities, the enablers, the challenges that we face, and we'll work through that through the audience. I'm then going to speak about some of the directions ahead as it relates to HQO and get your input as we go ahead. So we'll kind of tag team along, but that's how we're going to try and approach things.
Great. Thank you. So as Jeff has said, in preparation for this meeting, we were fortunate. We decided to actually survey people that had signed up for the session at that point and get some feedback. So we're going to be sharing that with you. Before I do that, I thought that what I would do is share a little bit of the thinking around initial directions. And this is meant mostly to kind of place quality improvement in the current thinking of Health Quality Ontario and the work that we want to do in quality in the province. I'm not going to spend a lot of time on it because it's actually a general direction at this point in time. So the first thing I think as we've come into these roles and we've looked at what's happening in Ontario, and for me it's interesting working nationally and sort of coming back to Ontario in a sense, and feeling the difference. There's a noticeable difference in the province of where we are in quality. The culture is starting to shift, and the capacity in the ability to work on quality improvement, improving quality, has actually grown in Ontario, and it's quite noticeable. And so it's become quite an assumption actually to guide our work around what our general direction should be. We've sort of assumed that HQO should be functioning as a catalyst. And that means actually working with and through teams that are out there, communities that are out there, and partners that are out there. We really do want to look at how we can align the different pillars of Health Quality Ontario and really maximize how they work together. And that is something definitely that the entire HQO team is very, certainly has as part of its vision and really wants to ensure we can enable. We want to look at how we can invest strategically in leadership for the system. There was, again, we had the Ideas Alumni Day yesterday, and Susan Fitzpatrick came to that group and said, you know, you are the group that has sort of stepped up to say, I want to come for this training. I want to actually help to lead the change in the system. And we need to think about where and how we continue to support those leaders that are out there. And then another key assumption is that we will listen to the patient's voice. And boy, the last session that we all just came out of couldn't be more inspiring and motivating for the kind of work that we need to do together. So this really describes, again, the sort of three main pillars at Health Quality Ontario, and that we see them as interconnected and informing one another and working together with one another. Looking at the work that we do in evidence development and standards, the work that we do in quality improvement, and then of course, looking at what is our public reporting saying. So we heard from Irfan this morning on how are we tracking as a system, and I see that in the area of quality improvement, we've got to be looking at that and saying, well, where are we where are we going to focus our efforts together? And Joshua also talked this morning about the sort of system strategy and this coordinated approach that we might be able to bring. So these are just a few statements with those assumptions in mind, a few statements about generally where we think we'd like to go in the next few years. And the first statement talks about in the next few years with a network of experts, organizations, and quality improvement capacity connected. So a real commitment to working with and through those out in the system. And then by fully leveraging the elements of evidence and public reporting that we have, how can we be consistently proactive and responsive to emerging evidence and quality issues in a planned and timely way? How can we achieve some success on 1 to 2 large spread and scale initiatives? This, I think, is something that personally, as I've come in and I've been out speaking with people, a lot of sense that there's been a lot of local initiatives that have happened that are showing some successes. People want us to create the conditions so that people can learn more about how that happened and also share about things that didn't work the way that they expected. The third is really to be a trusted broker for QI, and it builds on that role. How can we actually connect to the quality improvement community so that they can see benefits from one another? And then finally, see an ongoing building of knowledge and capacity for quality improvement. One major initiative that we've got in that is ideas. There's many others that exist across the province. But ultimately, that our goal here is that we're working towards having a prevailing culture for quality in Ontario. So this is the moment where we say that's a straw dog. That's just generally where do we want to try to work towards. This session actually is meant to help inform putting some of the details around that. This slide basically outlines those 4 major goals around how we can plan together, catalyze QI together, look at how we connect the QI ecosystem and how we build capacity. But seeing the quality improvement plans is an important lever in that. How can we, what's wonderful actually is that we've got coverage on quality improvement plans now across hospitals, 4 years of experience with hospitals, CCACs, long-term care, and primary care. So how can we, and so we're starting for a portion of organized primary care specifically, but how can we start now actually bringing the real benefits of that together? How can we start providing data back to the field on what we're seeing and what's working and the observations from that? The second is patient engagement and how that can actually help us in achieving some of these goals. This really, I think, is a slide that Jeff usually speaks to, but it talks about engagement, that we know that if we're going to do this well, we're going to have to really have ways that we are engaging the clinical community, engaging those actively working to improve quality, engaging with patients. And that secondly, we know that communities of practice work, collaboratives work, they can and are probably an appropriate place for a provincial organization like ours to help to support the system. And then in terms of current and what we call current and candidate areas of focus, I just wanted to mention a few of those. HQO is currently very involved with HealthLinks and supporting patients with complex needs, and we're looking at how that role should evolve and adjust as we move into the next wave of HealthLinks. Primary care, we've got several initiatives underway, and we actually want to work with the primary care community to say what's the best way for us to start advancing quality improvement together. And that largely is happening through a collaboration with the OCFP. In surgery, we're very excited to be saying that we're looking to bring the NSQIP, the National Surgical Quality Improvement Program, to Ontario. Integration of care is a theme of our new Arctic call. You heard about the Arctic Spread Initiative this morning. There's a call out as we speak that looks at how we can improve integration of care across different care settings. Patient experience and emerging areas such as in the area of QBPs. And what are some of the others? And we do feel at a minimum we've got to think about the Common Quality Agenda. It's an important grounding for us, and also how we can fully utilize quality improvement plans. So that's in essence a kind of just an orientation to where we are today, where we are with our thinking. But now what I'm going to get into is the survey that we did prior to the session, and this is where we really want to start some of the dialogue and interactions with you. We decided to send out a survey, as I mentioned, to people who had registered and in the session. In a week's time, we had 186 responses, so we thought this is great. This is a group that's engaged and wanting to provide us with their feedback. And what we thought we'd do today, because I think we've got larger numbers than that in the room, or we may have a different group in the room, what we thought we would do is actually work through the results, but then we're actually going to get you involved to also provide response to some of those questions. And we'll see if there's any differences between what we saw through the survey, through the initial survey. And really, it's meant to be some data that is a starting point for a discussion after that. So does everybody have a voting tool? Yeah? Okay, so we'll see if this will work. So here's our first warm-up question. What you will see is that you'll need to provide a response to this. You can see the numbers on the buttons. When you hit the response, you'll see the number in the box, and then and you'll see a green light go. And so that's when you know that your response has gone in. Okay? Everybody got it? All right, so let's vote for when we think the Toronto Maple Leafs will win the Stanley Cup. And is the timer? I'm just as a bit of a check of our system. Yeah. Thanks. Okay, great. Oh my goodness! Wow.
Not a lot of people here.
Not a lot of
Toronto.
city. Yeah, I was going to say. You could tell there's 10% that live in Toronto here.
Clearly, nobody has box seats.
That's great. So this gives us just a practice to kind of get us warmed up. So let's move on. So the first question that we asked on the survey was, what healthcare sector or type of organization do you currently work in? And our initial survey showed about 25% from acute care, 13% in primary care, and then you can see some of the other various organizations. So now we're going to get you to let us know what healthcare sector or type of organization do you currently work in? Is the timer going to come again? Great. Great. So now we can see the results side by side there. It looks like actually we've got an increase in a few more from government agencies in the original survey. About the same balance across acute care and primary care, and a few more from the long-term care sector participating. Okay, great. Let's keep going. This is just to get us warmed up a little bit too. So in your organization, what is your primary role? And as you can see, we had about 30% that identified themselves as quality improvement leaders. We had a fair proportion that were in both management and executive roles, about 8% that were health providers, and 21% in others. So let's see who we have in the room here today. Let's see. So it looks like we've had a reduction in the number of executives, and we've had about the same around quality improvement. And I don't know, pretty similar otherwise overall, eh? See any other changes there? Okay, great.
I think the question should be, are there people that are not in the room that should be in the room? Mm-hmm. And do you think that the people that are in the room or they're represented in the survey are the people who are going to be instrumental in making change? Mm. And mm-hmm. One group, I think we'd all recognize patients. We've already talked about that, but beyond that,
yes.
Other people, or do you think we have got a good mix?
Carol? So if I read this right, 9% are healthcare providers? Yeah. Although I suppose it'd be a good question for the group if you're a quality improvement leader or healthcare provider, you know, is there any dual role there? But 9% are identifying as healthcare providers.
I thought that was interesting too. I thought there would be more who would identify themselves as primary providers of some form or another.
Yeah.
So to your point then, it's not good to have a divorce between primary care provider and quality improvement.
Yeah, no, fair enough. Yeah, fair enough. That's great.
So there's mics that are circulating around. So throughout the course of the morning, feel free to, if you want to say something more, though, a mic will come to you. But you'll have to use a mic.
I think it's also the question, though, because on that, I'm management and quality improvement leader and provider, and I answered provider. So I could have answered many different things. in
Right.
there. So you may want to say all of the above or some other mixture, because I think it depends on what hat you happen to be wearing today sitting in this room.
Yeah, it's true.
I'm glad that everybody's getting the opportunity to use the mics. If they were actually on, that would be helpful.
That's great. Yeah. Yes, please. Yeah, is there anybody else? Great. I think it's a good point. So, but we certainly would want to be sure that we've got them in the room as we continue. So the next section asked about identifying QI goals and priorities. And we wanted here to get a sense of actually within your current organizations or the places that you're practicing, what are some of the priorities? And we asked, we sort of did this according to the dimensions of quality. We certainly had some comments back that, they're all important. And, none is more of a priority than another, which is true. We want to be sure that we've got a balance. But if people are identifying their top 3 priorities or are ranking them, how would you rank them? And so this is what we are seeing. We're seeing that safety is still being prioritized overall, followed by patient-centered and accessible. And I think as well, what we thought we would do now is ask you that same question again, but then we actually thought we'd work through some questions and discussions about why did those 3 surface to the top. And we've also got some questions about why were the ones that were ranked as least priority, why did they surface there? And those, if you look at equity, nobody actually ranked that as their highest priority. So we'll come back and we'll vote at the end. So the first question was, the first discussion item is around patient safety. So 30% of respondents ranked patient safety as their number 1 priority. And so we thought it'd be interesting to hear from people what aspects of safety are important to your organization today. Have you seen a shift in the focus of the safety elements that you're working on? And then 15% actually another observation was 15% ranked safety as their last priority. And so we're curious as to why it was your last priority. Any comments on patient safety? Yes, please. So it's going to be really hard at a big room, so thank you for bearing with us.
I guess I'd prefer to go to a specific example if I could, just because that's going to help to conceptualize for me. And one of the biggies I'm aware of in our institution is hand hygiene.
Right.
Okay, because we're trying to get people to wash their hands. There are different mechanisms going on, different education sessions, and we're able to get very short periods of time to get staff to wash their hands before they see a patient. And this is also a change in the culture and another time commitment, and there's a whole lot of issues. And to me, one of the big things here is getting the health professionals involved as well as the quality improvement or the management people. This cannot be a top-down kind of thing.
Yeah.
So I guess that's just my first thought. Because I also think if you ask every patient, 100% of them will say, yes, the staff should wash their hands before they touch me.
Yeah.
I don't think there's any question there. So yes, patient involvement in this case would be important, but I don't think it's going to tell us anything, with all due respect, you know, because I think that's the issue there. So I'm just going to throw that one out if I can.
Yeah, no, that's great. And honestly, like, this is exactly the kind of conversation that we're hoping to start here. We really want to get at what are the practical focus over here. Please come up to the mics as well. The standing mics are there.
I was just thinking of the last one, if safety was your last priority, why? Mm-hmm. And I was just actually thinking of the talk this morning where the father was, I'm fighting a cold, sharing the story about his son. Myself, I'm a new mom. I think I think whoever was answering that question was just thinking patient safety is just a given. We live here, we take a lot of things for granted. You think of stories of families that are suffering in Africa right now, and for us, I'm just thinking as a new mom, I would just be a given that my child is safe, whoever's watching my child. So I'm thinking that's maybe what's in people's minds, that patient safety isn't something that I have to concern myself with. A healthcare provider or wherever my child goes or wherever my loved one goes, they're taken care of.
Yeah, good. Thank you.
So that concept of above all else, do no harm,
Yeah,
you know?
yeah.
I mean, that's sort of a,
I also think it depends on where you are on your arc of performance improvement. A lot of our healthcare organizations have already tackled patient
Yep.
safety.
Yeah.
The hand hygienes are already, the processes are already in place, the reporting is already there, so the focus
Yeah.
is on other areas.
Yeah.
so the comment was it depends where you are in the process of quality improvement, and a lot of hospitals are fully immersed in the safety agenda. I think that's exactly true. And however, I think if you find yourself out in another context, safety then becomes long-term care, for example. You know, how are we dealing and how are we monitoring safety in that context?
Yeah. Yes.
I had a little difficulty with that question because I wasn't sure how to define priority. Was it priority in context of the current initiatives that we have in place? Is it
Yeah.
priority in the context of overall how our organization has been performing through time? Some of the priorities that you listed, we tackled, have processes in place and are dealing with on a daily basis.
Yeah.
And so in terms of advancing a new set of quality procedures, they're not a priority. They're part of the operationalization already. So perhaps defining the question a little bit more. What are your priorities now? What are your overall organizational priorities? And what do you plan to do in the future might have been a bit more helpful.
Okay.
So we're going to get them to vote.
We're going to get you to vote about.
Why don't we, that's a great point. I mean, what are your
Yeah.
current priorities? But I think it's very important to think about where your priorities are going to be.
Would be.
And then, because that's our job, to facilitate you to get there. And so it's not so much where you are now, but where you want to be. So that might be something
Yeah,
we'll think
and-
about when we're going to get you to vote.
And I think when we did initially do it, it was around your current, like we were trying to understand sort of the organizational, and one of our own observations was some of the system priorities were lower, but that's not unexpected necessarily if you're looking at it from the perspective of our own organization. So, but thank you for making the point, yeah.
Darren?
So on the safety front, so we spent a whole day yesterday at Cancer Quality Council signature day talking about safety in the cancer system. Spectacularly important because when safety goes wrong in a really bad way, the impacts are incredibly high. Also low-hanging fruit when it comes to making impact because it is a tangible, it is a measurable, and in many cases you can document where safety risks are and how to improve them because it's something you can put a finger on. So it's high priority for many reasons. On the low priority scale, though, what I am very aware of is that it's very easy to push safety off to somebody else's business. Right? I'm ineffective in this domain. I personally can't make a difference, which is a culture issue. So we spent half the day yesterday talking about safety as culture and being something that's embedded in the work that we do every single day. And in fact, certain jurisdictions like NHS Scotland have done a spectacular job of systematically focusing on safety as a #1 priority for the entire health system. And I don't see us doing that here. And I think there's a hesitancy and it needs to change.
Yeah.
Far easier to deal with than aspects like equity or in other very tough quality domains. But safety definitely there, and we need to actually own it.
Yeah, great. Thank you, Darren. Great comment. Yeah. Shall we move on to the
Yeah,
next one?
perfect.
Should we keep going? So the next one that surfaced was that was patient-centered. 19% ranked being patient-centered as their top priority. Another 20% ranked it as their second most important priority. Again, we just wanted to get a sense of what is it that people are focusing on around this dimension, and why is it important to your organization? And I'd be very interested in different sector perspectives on this as well.
A lot of people talk about it,
Yeah.
but to be honest with you, I'm not exactly sure what they mean.
I think it all depends on what kind of client population do you serve. Some of those client populations that are underserved, that have great barriers to access health services, whether because of language or because of disability or because of low like determinants of health issues, those organizations are more focused on lowering those barriers and ensuring that the services that they are providing to their clients are actually the right services that would work with those populations. So like community care and those kind of populations.
This would be another great one to ask what you're doing now or what you would like to do.
Yeah.
Because to be honest with you, I suspect this is more of a hypothetical. I would love to be more patient-centered.
So I work in long-term care and with complex frail seniors who are housebound. And for that population, we have to be patient-centered because we need to know their goals of care. So that housebound, frail, complex population, we really try to work around with an integrated team around what the goals of care and try to support those individuals. In long-term care, there's a lot of talk around patient-centered care because we have the Long-Term Care Homes Act that is embedded in resident rights and resident focus, and it is individuals' homes, and it's usually their journey to end of life. So we try to be patient-centered in that care, sharing care plans, having the residents and their families participate in what our plan of care is, lots of family conferences, meetings, et cetera. We're not doing a perfect job, but it certainly is a sector where there's a lot of patient-centered work being done.
Excellent. Great. Yeah. I think there's a mic back there, so go ahead. Oh, sorry.
In public health, one of the things that I'm finding is trying to get people to understand the difference between when we talk about client-centered, doesn't mean some of the health equity stuff that's happening in terms of knowing what's best for people and talking about what might be best for them. I'm trying to move people into that idea of the nothing about me without me. So it's going to be a journey. You'd think it would be easy, but I find how do we do that? Is it, we could do a focus group? But no, it's working towards that like the Voice of the Customer Health Quality Ontario document that talks about collaborative service delivery.
Yeah.
It's important.
Great. Thank you.
Hi there, I work for the Access to Care program at Cancer Care Ontario. And organizationally, CCO has actually adopted something called person-centered care, not patient-centered.
Yep.
And that's really about a philosophy. And one of the tactics of person-centered care is around patient and family engagement. And then the results are an improvement to patient experience. CCO has a Patient Family Advisory Council, and we have over 80 patient and family advisors. And they don't just sit there to listen, they're actively involved in the decision making around how we're advancing our cancer plan, our renal plan, and now Access to Care is looking at would there be opportunities for us to have patient and family advisors, even though we're indirectly involved with healthcare. So that's what we've been doing as an organization more broadly, and it's very different than patient-centered.
Yes. Yes, absolutely.
I spend a little bit of my time in kind of quality and best practice and a lot of my time at the bedside in a hospital, in an acute care setting, and we hear a lot of talk about patient-centered care. I'm also a speech pathologist by training, and I think that I love the comment about the person-centered care as well. I see a real push and pull between wanting to be patient-centered and system factors. So we hear, it's our top priority, we hear a lot about patient-centered care, but then we also hear a lot about flow. So to marry the kind of economic and flow, and it's so complicated, but to try and keep the patient in the middle of it is difficult, and on the front line as well, because I see my colleagues losing their patient-centered care because of other things that are going around them within the system. So any ideas would be fantastic, but it's a real dichotomy, I find.
Yeah.
And I think anybody in the acute care sector would sympathize exactly with those comments. You know, I can tell you my hospital yesterday morning, we're 110%, 115% occupied. We had 55 people in the emergency department, admitted, no beds. The usual call goes out at 10:30. Everybody's got to leave because we've got to move these people. We tell somebody, an elderly lady, 90 years old, you've got to now go home. It's 11:30 at night or 1 in the morning. And is that really patient-centered? You know, but you got to reduce your length of stay, and you've got to get flow going. So it's that challenge that we face, and I see us moving in acute care sector to some extent farther away from patient-centered because of those other priorities that face us all day long. So I'm all over what you're saying.
Yeah. Good. Anybody? Yes.
Hi. I'm here from Medical Laboratory Services, and so we've always been focused on client-centered, getting those accurate test results to our healthcare providers as quickly as possible. And we're trying to move our patient-centered quality initiatives sort of more on our education front, trying to educate laboratory technologists who are very removed from the patient around patient-centered being the sort of art and science coming together and providing that kind of care. So we're trying to move our quality initiatives that way. Every tube is a patient. It's difficult when you work in those healthcare paramedical groups that don't have direct patient contact. Of course, our patient service centers do, but our laboratory technologists don't.
Great, thank you for sharing.
But the challenge I think you face is that you're probably as essential to the services for that patient as the provider that's right in front of the patient that particular day. And as is the orderly, as is the person who's bringing the meals. And how do we make them a part of a team that focuses on quality and patient-centeredness or client-centeredness?
Any last comments on this? Oh,
Hi, I'm from the Ministry of Health, and it's really interesting to hear all these insights from the field. And one thing that I think the person who was speaking from Cancer Care Ontario really helped me to discern the difference between the patient experience versus flat satisfaction surveys, right? Like I think sometimes for me, like I might think that, oh, we're engaging a patient because we're disseminating patient satisfaction surveys, but the challenge of actually measuring and quantifying their experience and balancing that against the realities of the front line, right? Like it needs to be patient-centered, but it also needs to be balanced in an equitable framework. And so it's very interesting to me to hear these conversations, and I think the desire is there. It's just building the structure to support that so that it's standardized across the province, irrespective of the patient or the geographic location, et cetera.
Right. But I do think it is important how people think about their patients, their clients, et cetera, in different ways. And in some ways, even the way we articulate this dimension of quality probably needs to be sort of updated in a way to be more reflective of current thinking. Yes.
I've spent about half of my career doing reporting and analysis for for acute care and half of it for community care. And one of the things that I find is funny is that in community care, there's always or almost always a patient representative on the board of directors. And I think that's something that if you want to become patient-centered care in acute care or in CCACs, you got to get a patient or family member representative on the board.
Yeah.
That's the fastest way to drive through change.
Can I just drill down a little bit on that? Exactly right. The acute care sector has hospital boards, which are made up of community members.
Yes.
However, that's about where the community involvement ends.
So I've sat on a board of directors for a very small organization, and our mandate is to have at least 3 patient clients, or 2 or 3 patient clients on the board of directors. And I think that the hospital said, well, we got to have at least 1.
But if you had them in the operating committees of the hospital, that's when you're going to see the real action take place.
And I think we're starting to see that level of engagement.
Especially Kingston has been
in different places. And certainly, as you heard from Joshua this morning, we're even trying to really aspire to that within our own organization.
Good.
Oh, one more comment.
I work at Hotel du Hospital in Kingston, Ontario, and it's an ambulatory care centre. And patient-centeredness is one of our strategic priorities. And having said that, we're very early on in our journey. One of the things that we're doing this year, which we're all supposed to be doing, but it's not easy, is we're meeting with the Patient and Family Council to engage them in our discussions about our priorities for next year's QIP, Quality Improvement Plan. And we're trying to get some sense from the patient perspective of what they would like us to see as our quality priorities for next year.
Great.
And because this is our first year in it, doing this formally, I expect that we will perhaps learn a lot this year, and perhaps we will get better at doing this in years to come.
Yeah.
And the other thing that we're doing this year, which I'm personally finding a bit scary, is that we've invited a member of our Patient and Family Council to sit in on our budget deliberations for next year. And like all hospitals in Ontario, we're challenged to maintain a balanced budget. And so bringing the patient perspective to those, what I assume will be difficult discussions about balancing budgets, it'll be interesting to see how that turns out.
Oh, wow. Good for you. That's great. Very interesting. Well, we're going to keep going. Thanks for sharing all of those various examples. The next is about accessibility. This was sort of ranked third, and again, we reflected a little bit this morning on where we are in Ontario and Canada and access more generally this morning. So again, when we think about access now, what are the areas that people are focusing on? I think that what the data is showing is that we've had some successes in this area, but there are some other areas where we still need improvement. So what are some of the examples of what people are focused on?
Again, I think that this is where would you like to see it, as
Yeah.
opposed to where is it right now.
Yeah. Yeah.
Where's the new horizon that access is the challenge?
Hi, so my name is Leslie. I work for a community health center in Kingston, and we have a problem with access because of the way that we're funded. We provide a whole bunch of discrete services, but they're funded through different streams. And so we've got situations where if you live on the wrong side of the street, you can't access our Pathways to Education program. If you live too far to the south, you can't access our Better Beginnings for Kingston Children program. And so, and we also have, of course, our primary care services as well, but it's difficult for us. We're trying to look at an integrated access point, and then we come up with these barriers because our funding requirements prohibit us from providing comprehensive care.
So can I ask, what would you see as the I mean, I have my own thoughts exactly, because I experience that all day long. So I have my own thoughts. How would you see the solution? Where would you see the solution in that? And how could we help in that?
Well, in our organization, we have 6 IPIs, Integrated Priority Initiatives, where we're trying to look at integrating access and services across health, across the lifespan, youth, seniors, maternal child health. If we could have more freedom in our funding and more ability to actually look at exceptions, or to say, if somebody accessed this point and they met the criteria for our Better Beginnings for Kingston Children program, but they also have a teenager who would benefit from the Pathways to Education program, they happen to live 3 blocks away, can we do that? So I think that there are opportunities to look at some more flexibility over time.
So shifting down the funding structures and the accountability down to the grassroots and allow them to make essential decisions as they say on a regular, ongoing basis. Hold them accountable for outcomes, unquestionably, but allow the decision makers who are faced with the unique circumstances on the ground to make decisions that are best for their community.
True. And looking just at we have geography problems, right? Because that's how our funding is set up.
Okay. Anybody else on access?
Hi. Can you hear me?
Yeah.
Yes.
So I work in North Bay, Ontario at a nurse practitioner-led clinic, and our problem across our region actually is about access to primary health care providers. We have doctors we had 3 family doctors who retired last year. And so we have an influx of orphaned patients. There are 4 nurse practitioners. We have the funding for 4 nurse practitioners. And you know, we estimate that in a community of 51,000 people, there are 10,000 orphaned patients. So for us, that kind of accessibility to just primary care is huge. And we hear in, I know that I'll be going to a learning session on advanced access. Thank you, Health Quality Ontario, for that. We've done 2 waves ourselves, but there's a family health team in Sudbury where there are 3 MDs, and they are servicing 10,000 patients. So accessibility, even if you are rostered to a healthcare provider, and you have to wait over a month for an appointment, is really, really difficult. So for us, access, patient safety is definitely, it's sort of a given for us. It's an operational given. But access is where we see the potential for improvement, even a tiny little step of improvement.
Great. Thank you. Yes.
I also work at a community health center, and a couple of points. I guess one of you had mentioned earlier, people had responded to you that all of these dimensions of quality are important, but they're also interconnected, right? So at community health centers, one of the major access issues that we have, access to primary care, primary health care for folks who are without OHIP, who are living on the street without identification. There's a whole bunch of different components that make up that lack of access, and they're folks that really won't be captured within the mainstream population. So, you know, funding barrier for sure is no base funding increases to the community sector for the past many years, community health center sector or other similar sectors that also serve those who aren't captured by OHIP, aren't captured by the mainstream. And then there's also the federal component of reductions to the IFH program. There's so much that's involved in there, and that's a major access issue.
They're not going to just wait longer on a wait list. They'll never get on a wait list.
Never get on it, yeah.
Good.
Okay, and the last one that we put which were some of the ones that did not surface, and thought 31% of response ranked population health as their last priority. As we mentioned, 0% ranked equitable as a first priority, and about only 4% actually ranked the appropriately resourced as a number 1 priority. So again, we thought we had some initial discussion ourselves about, well, what does this mean, and is it, you know, partially because of the nature of the way organizations work, sort of, and have their own approaches. But we're interested to talk to you about, you know, why did these show up this way, and again, where might they be placed if we thought about future work that we would do.
Or is this the same question we heard, you know, where's our priority right now, as opposed to where, aspirationally, where should our priority be in the future?
Yeah. Anybody want to comment on this? Down here in the corner? Yeah. Please feel free to just come right up to the mics, too.
Sorry, I realize that the purpose of this exercise is just to rank to get an idea of where everyone stands. But it's just I find it very difficult because I'm being forced to rank these things, and equitable and access are all kind of number 1. They are, although we may not be doing a great job when it comes, but the idea is, so I'm forced to sometimes say equitable is last because I'm working on something very specific to access at the time of the questionnaire. So I just thought I'd share that with you, you know, because that's not truly a reflection of what my thoughts are, and I realize I'm not the only one that took the survey, but to share with you that I don't necessarily think that it's least priority, but that's the sort of thing that goes through my mind when I'm answering that question.
Yeah,
so
that's great.
Excellent. Thanks.
That's great.
Hi, my name's Brent. I'm an industrial engineer by background. I'd like to, I guess, maybe just put out there as a bit of a concept from another industry. If we think of, let's say, the automotive sector as a sector that really is, over the last 25 years, has transformed itself using quality as the key driver. I think that a lot of it comes down to really looking at quality is defined by the user at the end of the day. It's defined by the person who ends up buying the car. And of course, if we look at some of these things, they wouldn't say, well, the steering wheel isn't important to me or the tires aren't important to me, but they probably wouldn't put that on a survey. But it's the whole experience of buying the car and using the car and maintaining the car over its lifetime. And I think those are the things that ultimately really drive quality. And if we measure it from an experience perspective from the patient, I think these are all aspects of that experience. And so I think to me, it's important to really put the patient experience in the window. That's the most important thing. And measuring that and measuring all of the different dimensions of that will, I think, help inform us as to where we should invest our resources and time to make it a better experience.
And if we look at the report card, how many of those things that we put in the report card do you think are really what reflect the patient experience? Not many. Yeah.
And particularly the overall patient experience across.
No, I appreciate that.
Right? I mean, they're all
That's
important, but they're not what we see as a patient.
Yeah. Great. So I'm going to keep us moving. Then the next session, what we wanted to do here was we felt it was really important that we were sort of asking where the priorities are. Irfan has taken us through what we've seen in the report, but we thought it would be good to sort of say how does where we're measuring up as a system compare to where our current priorities are. And after this, and we've only got a few slides in here, after this we're going to vote on the question that Jeff keeps putting back out to the group, which is where should we focus in this. So this is just a reminder that the indicators in the report that hopefully you all picked up on the way out the door today are measures around the common quality agenda by sector. Certainly these are a set of measures that will continue to evolve over time, but for this year, this gives us some sense of how we're doing overall as a health system in Ontario. When we look at some of the key themes, we saw that our health system is improving overall in some areas, that access continues to be a challenge in some areas, that integration is a challenge, and that there's variation across Ontario. Those are some of the key things that sort of came through the discussion this morning. When we look at the priorities that we've identified, they were safety, patient-centered, and accessible. Again, going back to the point just made near the end, like we know that we were kind of forcing a ranking here, but those are the ones that surface. So when we look at how some of the data from that report as it relates to patient safety, this shows the rate of hospital-acquired C. difficile infections, which has been remaining fairly stable over the last several years. And the percentage of long-term care home residents who fell in the last 30 days, the same thing. So in some ways, this could represent the fact that people have some of the comments from the group, that we've worked on those and we focus on them and they've kind of got to a level and they've remained stable. But it would still sort of say to us, is there opportunity to still improve in some of these areas? The second area that we looked at was what were the measures of patient-centered care. Again, I think this morning we've had a lot of discussion about what that means and what it means in different sectors. But on the left-hand side, you see some of the hospital satisfaction data that looks at the respondents who would definitely recommend a hospital to a family or friend after their experiences is in the inpatient or in the emergency department. And I think that, we see some difference between the emergency department and the inpatient care. And I have to admit, on these kinds of questions, I think it's always important to sort of flip it the other way and say how many people were definitely not, right? The sort of reverse of that. The one on the right looks at the percentage of survey response who report that their provider is always or often giving them opportunity to ask questions. Overall, doing fairly well on this indicator with some variation across on the LINS, but overall, I think giving fairly high marks in this area. Next slide you saw this morning looks at timely access. It continues to be a challenge, particularly to primary care, and certainly, we're doing we're sort of middle of the pack relative to the rest of Canada, but as we compare with other jurisdictions around the world, still have a lot of work to do in this area. And then really integration is a challenge, and integration as well is a challenge in terms of some of the variability we're seeing. This is the measures of alternate level of care, days in acute hospitals. We know this is just one measure indicative of the level of integration care, and they really access as well then to particularly long-term care. And again, this is an area not only where we see that we've still got work to do overall, but that there's a lot of variation that we're seeing across Ontario. So now what we thought we'd do is ask you to think, to rank. So given that data, given some of what you heard this morning, given some of the conversation we've had today, here again, we're going to ask you to do this again, which is to sort of say, which would be your top 3 priorities for where we would work, that we would prioritize together in the future. And to do this technically, you just need to put them in rank order, and you won't be able to correct it. So you might want to just think for a minute before you enter your responses to it. Can we just start the timer then? Okay. So here we're seeing some of the same trends that we saw previously. Certainly this emphasis on patient-centered, and again, the variable ways that people are thinking about that in their work, and certainly safety and effectiveness have sort of risen to the top in that. Anybody have any comments that they want to make about themselves? No?
And not only silos of care, but silos when it comes to the electronic solutions. I work in a community health center. The hospital we're related to, we have a timely discharge information for patients who had been admitted. We have a 3-week lag time from ER reports. That's just not acceptable for them then to come and be seen by primary care within 7 days, because we have no idea what's going on. So I think Health Quality Ontario could be really a partner with establishing some sort of initiatives with eHealth to really move them along more quickly to getting MDs onto, or primary care in general, nurse practitioner-led clinics, etc., onto one system or choice of 3 that speak to the hospitals, and the hospitals to make sure that all departments are linked electronically, so we can be linked electronically and we can serve this.
Great. Thank you. Yes, Darren.
I'm quite concerned that equity is ranked last, I have to say. So as a provider, as now working in the domain of sort of system leadership and health policy, I know that social determinants of health, like poverty, is the #1 predictor of health status. And equity has an impact in every single one of the other domains that we see in front of us. And if we don't somehow grapple with how to deal with social determinants of health, we're never going to get any kind of cost control, never going to manage population-based health in a real way. Efficiency, effectiveness will never be solved. And we're just going to have this same wheel being reinvented over and over again. So I think at some point in time, HQO has to have some major focus on equity. It's not now, it's next year, sometime soon. And this is the hardest one, so I get it. It's not the one that everyone wants to grab onto, but it's potentially the most impactful domain, in my opinion.
Yeah, thank you, Darren. Yeah.
And I didn't put Darren up to that at all, honestly.
Yeah, exactly.
I just had a comment. I worked for a LIN for the past 6 years. Hi,
Where are you?
here.
There you are. Hello.
And I just started working for a hospital on Monday, so I'm really new there. But one of the things I've reflected on a lot working at the LIN is the fact that the things that we held hospitals and our other providers accountable for are not some of these things. So we don't have any patient experience measures in the accountability agreements that we have with providers. We don't have any equity. So I don't think that it's that no one agrees that equity or patient-centeredness isn't important. It's that what they're being held to account for are things like access, wait times, and flow. So I think, you know, the reality is HQO has no authority over any hospitals or any other providers. So the things that you guys are trying to enable in the system and encourage are what everyone wants to do. But until the two things are aligned, I think we're going to continue to have pressures with people feeling overworked and not enough time to focus on the things that they want to focus on. So.
Great. Thank you. Very good point. Yeah.
The Toronto Central did put health equity reporting in their accountability agreement for long-term care and
Yeah.
so I worked on that project. It's quite a bit. And
Just say it again. Did
sorry.
people hear what he said? Yeah.
The Toronto Central LIN put health equity reporting, which is 10 required questions and 3 optional questions for every patient for hospitals and long-term care in Toronto, and that data will start coming out and will really show some differences in costs and levels of services and worse outcomes for people who don't have equitable access.
Good.
Minorities and
That's great. But I do think this is a good point, and I have a feeling my colleague might agree with you up here. In particular.
It's interesting running through the project, which required every single patient who came into the facility to answer the 12 questions, which include, family salary ranges and income and all of those kinds of things. Lots of pushback from the healthcare providers, and a lot of them didn't think that equity was really an issue.
Right.
There's a belief amongst the healthcare providers that they provide the best level of care that they can to their patients, but no real data behind it. So it'll be interesting to see when this comes out, how all that stuff plays out at the patient level.
That's great. I am going to just keep us moving to the next question, sorry, because there's another section that we really want to get to, which is some advice from you on kind of where we can focus. We're hearing some of it. But you know, we do want to keep going. So sorry for the person back there. Take that chance if you can in the next section to make the point. The last question we had was, is there a sector itself that you feel like that you would prioritize at the moment in Ontario? If you had understanding that system integration is important and a priority. But again, going back to kind of the patient experience, is there a sector itself that you think that we should have an emphasis in, more emphasis in? Yeah, you have to pick one. We know that, again, that's why we sort of said understanding that system integration is a priority, and we know that we've got to do that together. You okay?
We have to end in 5.
And how many? Okay, we'll go till 12. Okay, great. So we're seeing 41% for primary care, and we're seeing 33% in home and community care. So some pretty strong, emphasis in those areas. Okay, I think we're not going to be able to discuss it. I think we should keep moving. And I'm going to hand over to you. It's actually it's about 20 to 12. I think technically the session was supposed to end at 11:45. Is that right, Shilpi? Yeah. Are people okay if we continue together until at least 12? I don't think we'll miss too much of lunch. We'll just miss the line. Yeah.
We'll try and.
Because we really would like to get some.
Let's try and bring it to a close soon. So.
Yeah, and we did start a little bit late, so.
I'll go through it very quickly. There's 2 aspects here that some conversation is needed about, because this helps us direct ourselves in the future. So this question related to what are the 3 most challenging aspects of doing quality work in your organization? So at an organizational level, what were some of the challenges that you were facing? And I think it's important to note there that you've already reflected those back to us today. You've told us about silos and lack of motivation to collaborate. So how do we, without all of the levers, actually move the agenda forward? Secondly, for you, it was lack of financial support. And I think that we would all say that, interestingly, you said earlier on, resources was not necessarily a big thing, but I think financial support for quality to make this a reality. And I think that's important. And then lack of motivation to implement. I think also we have a static system, one that is very hard to break and unfreeze and to move us ahead. Interestingly, I'd like to reflect down at the bottom, which I think is interesting as well. So not considered feasible. You all thought, a majority of you thought that this is something you can do. You know, so that led me to have some degree of optimism, and you didn't think that there was a lack of support or management and administration. So I think that we are starting to see, even though we have silos, lack of alignment that you've told us about, you do start to see the sense that this is something we can get done, and there is starting to be alignment, or at least willingness to work through all levels of the administration and support for that. So I think that that's an important thing. And then individually, this is the next one, you reflected back to us lack of protected time, lack of individual resources, and I suspect that reflects from the earlier point, and lack of teams' capacity to implement QI initiatives. So do you have all the levers? Can you influence your colleagues around you? In a system where you don't actually, you can't hire, fire, or whatever, and you have to make things happen by coercion or just people doing the right thing. So I think that was an interesting part you reflected, and lack of financial support. Then go down and look at the bottom. I think there's some important lessons there. Lack of recognition in the clinical setting. I think we're getting there, frankly. Lack of recognition in your academic setting. I think we're starting to think about the new academic horizon in the academic health sciences centers might be the quality folks, the quality cadre of individuals who meet, publish, get research grants. And I think that that's a very positive initiative, and that's one that we have to continue to foster. So if you looked at those themes, and then we'd just ask you these questions. So the themes identified in my mind that there was some very important systems change, and you told us about integration and alignment, promoting leadership, and enhancing infrastructure. And that's what I was getting out of that from your survey. I'm a bit worried about leadership, frankly. I think that we have a small group of people who are doing a whole bunch of stuff, and we're at the risk of burning them out, and we have not gone to that level below to make it a more widely accepted infrastructure that everybody's doing this. Some perhaps are taking leads, but there is a sense that everybody's involved. I get the sense that this is still at that stage where you have a small group of people who are doing stuff, and you're either going to get tired pretty soon, you may be tired already, or you're going to leave that pilot project that you did in ideas or something like that, and then you're going to go back to where you were before, doing what you were before. In which case, that didn't move the whole system ahead. See what I mean? So I'm worried about the sustainability of that. So I'd love to hear your comments. We're not going to keep you much longer, but I'm going to ask you to vote on this one in a moment or two. But what are your comments about? Is that a reasonable series that came out of that first survey as a reasonable set of assumptions?
Shall we vote?
I know everybody wants to go to lunch probably, but just from the physician's perspective, in long-term care, quality improvement is happening. And we actually did a similar survey of medical directors and physicians in long-term care and got similar answers, which helped us to develop or implement, collaborate with HQO to do quality improvement training for those people. And we've now trained over 120. And what's really interesting is how we started the training was, what's the biggest issue you're facing in your long-term care practice, and how can QI help you? They all were really, really easily able to identify their problem. No one could say how QI could help them. And as the day went on, the light bulbs were going off. So some of this is knowledge, education, and the language. So a lot of people who were at a training said, well, I'm doing this, I just didn't know it was QI.
Yeah.
So I think we have a long way to go in terms of supporting the sector and people working in it, but there's a lot of, once people get the language and start looking at it, there's a lot of excitement that happens.
Great, thank you. Yeah. Oh. There's somebody at the mic behind you.
No, go ahead, don't worry.
Really quickly, I feel that my conundrum perceptually is a bit of a Maslow's hierarchy of needs, right?
Yeah.
And so with these questions, I'm having a hard time kind of. So we do have that fatigue that you're talking about, and I come up again and again against this sort of another quality improvement project? No way, right? Like this sort of burnout, and my challenge is to help them understand. Well, this is to prevent that burnout. This is exactly what you tell me what would improve your workflow and so on and so forth. So just for a pitch for ideas, Ideas was awesome in giving me the tools to have those conversations with our staff.
Great.
I'm just adding on to that and kind of piggybacking off of your comments. With respect to leadership and that burnout, so I'm a consultant at St. Joe's Hospital and with the quality department, so I work with the ED, medicine, et cetera. And what we always try to do is build that capacity with the frontline staff by providing them with small tidbits and tools. And I find what the barrier ends up being is they don't have time. They feel they don't have time. And so they want to do it, they see the results, they think it's great. But then they're just like, I have all these patients I have to look after. I have to do my rounds. I have to do my forms and connect with all the other providers. So it's really having that protected time for them to then take those tools and implement them.
So to me, that speaks to that issue of the culture of quality. That at the moment, quality is done when you do your quality stuff when everything else is finished and your day's over, then you can do some kind of quality stuff, you know? As opposed to it being the meat and potatoes that's part of your practice, you know.
Okay.
Good. Is that?
I just
we'll
wanted
take
to
one last comment.
One comment. Just I work with the Association of Ontario Health Centres, and we are gathering our leaders together, and we have a QI Knowledge Initiative where we're trying to find the centres that are, have that culture embedded. And this is like they've been at it for 10, 15 years, and they've got it. And we're gathering them together to figure out what we can learn from them and then scale that up to our other centers that are really struggling. And we're just at the beginning of this work now.
So wonderful lessons there. So could we just get you to use your keypad here and reevaluate where you are with these indicators, 1 to 6. So if you could, we'll wait for the little, there it goes.
Yeah, tell me about investing
Excellent,
in leadership. Yeah.
Fascinating. So very much along the lines of what we've been talking, that we really need strong leadership and support, buy-in all the way through the system, and somehow funding has to reflect the importance of quality.
Yeah.
So there's just one more, one less. Yep.
There is, right? Yeah.
There we go.
There it is.
And I'll just speak to this for you. When we asked you specifically what you would like us to do, you are very, very clear, and I think that reflects the challenge that you've told us about today. You've told us about silos and fragmented system and aligning quality improvement priorities, policies, and process. So that sense of oversight, that sense of coordination, that sense of bringing people together, providing accessible evidence-based best practices and implementation, and increasing focus on quality issues. And you can see the other ones, and I won't read them out to you, but interestingly, look down towards the lesser ones, providing development opportunities. I think that's still important, and I think we have to be focused in what we do, But I think that reflects that sense that there is a growing sense of people who have skill sets in these things, and that we want us to continue that, but our big priority better be to start to coordinate that system. So is there any other comments that you'd like to reflect on that?
We do really appreciate people have been making suggestions on this question through the whole session, so it's good. Are there any other comments? How we can best put that?
Thank you. So I'm Eugene. There's some question, actually, factors beyond the list. The list is really on the front line, which is really important. But for the HQO, there's a couple more things. I have been hanging around with HQO since its early start. Really, back to the session started, both of you introduced yourself, the new leadership, I congratulate. But I used to categorize HQO, all those quality organization, into categories. I use analogy, may not fit everybody's view, but may help to get message across. Like puppies. Some puppies follow them, because they are charming, cute. People like to follow them. And some puppies chase people around, like dogs, because they have teeth. People are scared and have to run. So for the quality organizations across different countries, they have a mix of those functions. Many of them serve as advisor and advocate on some degree, and they position themselves to give evidence, knowledge, and call some working group, panels, suggestions. But if suggestion just suggestion,
right,
and the whole world, especially as we mentioned in the hospital healthcare system, people doesn't every day change their behavior practice because somebody made a suggestion. And at the same time, some organization put some effort in to leverage some very impulsive kind of policy or measures to move people, even for the people who didn't want to move, so that improve the quality of their activities. Today's session in the Ward and their presentation, I was really impressed, especially he put the last slide, say the recommendation they put in, and nobody took on. That's not a rare event. It happens every country, every province, every place. My question is, for HQO with new leadership, how many theses, if you can count, from the act, which enabled the organization to do work, can really go beyond the recommendation advisory? Just in case any of those sections who don't take any advice with all the excuses, HQO can still pushing forward, let that quality improvement happen. Thank you.
Thank you.
So that's an excellent challenge to us, that to move the system ahead, we have to hold individuals accountable. And we have to be independent to do that, but persistent in that.
I just want to add one thing. I also believe that there are things that we can start doing today to actually start working on the situation that we heard about this morning, because it's not uncommon in our own system. And I think it's actually going to be how we work together, motivate each other, and actually, Jeff's point, hold each other accountable to get moving in some of those directions. And in some situations, we don't need to, it's not about does the government say we do these things. Actually, we have the ability to work together on those things together. So again, I appreciate your point very much. Thank you.
So we can get you to vote. I don't think we need to do that.
No.
We've used up our time and a little bit more than that, so we appreciate your generosity. If there's any further comments that you'd like to bring back to us, we'd love to hear them. We've heard yours so far, and we're going to reflect that in our future directions. And this is part of an ongoing conversation, so feel free to keep telling us how we could do a better job. So thank you very much for today. We really appreciate it.